Okay, so spinal cord injuries. This is any trauma to the spine cord or spinal cord. Some causes would be falling or like a car accident. This Your spine is made up of cervical, thoracic, lumbar, sacral, and coccygeal vertebrae. And easy, fun little phone number that you could remember is 712-554, and that is the vertebrae that are within those sections. Some cervical spinal injuries could be from hyperextension or hyperflexion of the neck. It'd be like any type of laceration of the nerve tissue by bone fragments can cause permanent loss of conduction. So here's a complete loss of spinal cord would be loss of all nerve function below the level of injury, which makes sense because it's complete. And then incomplete would mean that some function below the level of injury is remaining but not complete, so it's incomplete. Below T1, which is your thoracic, so below T1 you have paraplegia, and that's going to cause leg paralysis because your T1 is kind of right at the bottom. It's like in the very bottom of your back, so it's right by your lumbar, so that's why it's really close to your legs. So that's going to be below the T1, which is kind of going into that lumbar section. It's going to cause paraplegia. So it's going to cause paralysis to your legs, which would be 2. If you have any type of injury to your cervical region, which is your neck, you're going to be quadriplegia, and that's paralysis of all of the limbs. So we'll talk about hypertonia and hypotonia. So you're going to have hypertonia if the spinal cord injury is above that L1, L2, and that's going to be that hypertonia. So that's going to be like your spastic bladder. And then if you have an injury below L1, L2, that's going to be your hypertonia, and that's going to be like a flaccid bladder. We need to make sure that we're stabilizing the patient's spine anytime they have a spinal cord injury, making sure that we're maintaining a patent airway as well, depending on where that is at. Anything above C4 is a high risk for respiratory dysfunction. And remember, when we're talking about C5, keeps the diaphragm alive. So that's what it's very, very important to make sure that we are keeping a patent airway. We want to monitor for neurogenic shock and autonomic hyperdysplasia, and these typically occur T6 or higher, or above that T6. And also halo traction device may be needed for treatment or to keep that spine stabilized. And also just to remember that we're moving the patient as a unit. We're probably going to need about 3 people to help turn and reposition this patient for cleaning or just pressure reducing reasons. So neurogenic shock. So like I said, this is above that T6 vertebrae. This is going to cause bradycardia, hypotension, and temperature dysregulation. So what we can do is we can do vasopressors, and IV fluids, and then atropine. So the atropine is going to help with the blood pressure and the heart rate. The IV fluids are going to help with all of that, and then the vasopressors are going, like norepinephrine or an epinephrine, are going to help raise that blood pressure up. Autonomic dysreflexia is a life-threatening blood pressure issue. So this is extreme blood pressure issues. This is typically above like a 300 systolic. This could be, this is above the T6 vertebrae as well. It's going to cause, the main symptoms of it is hypertension, like a headache, sweating, and bradycardia, blurred vision. So the most important thing that we want to do here is make sure that we are setting that patient up. It is very important that these patients are sitting up as your first priority with that. Let's see. Just some common diagnostics for spinal cord injuries would be like getting your CT scan, x-rays, and MRI. Some autonomic dysreflexia, what we need to be watching out for is, or what we need to do is we need to find out what the cause is. Because this is an issue with the central nervous system and the peripheral nervous system that are not working together correctly. So we need to figure out what the issue is. And sometimes the issues are just that you have a tight bladder, which is like a full distended bladder, maybe some compacted bowel, like constipation, or maybe tight clothes. So we want to assess what is going on. What is this issue? We want to do a bladder assessment, palpate that bladder, maybe a bladder scanner. We need to be checking for we need to be monitoring the urine output, so we might need to instill a Foley catheter monitor for that. We need to look for the kinks. We need to do a thorough background, either by the chart if the patient can't speak on their own, when's the last bowel movement, and definitely remove any type of constrictive clothing if there is any. Blood pressure meds are only done after assessment. Headache is linked to the high blood pressure, so the pain medication is not necessary. Any Tylenol or ibuprofen is not necessary. This headache will be resolved once the blood pressure is stabilized again. And we want these people in high Fowler's position. We want to sit them up. So we want to correct all of that. Let's see if there's anything else in here. C3 is can't breathe. And then C3 to 5 is respiratory insufficiency. I think we already said that. Just know that brain scale below 12 is very bad. That pincothermia is when your body cannot adapt correctly to the temperature, so it adapts to the temperature of the surrounding area. Also, these patients, since they're not able to move around, they are at an increased risk for blood clots. So we want to give heparin or Lovenox to reduce that risk. Also for neuropathic pain, we can give medications, which would be Lyrica or gabapentin. Lyrica is definitely stronger. And then baclofen for any type of muscle spasms. So again, I just want to touch on these because these are really important too. For an incomplete spinal injury, your Brown Sequard syndrome, that is that your ipsilateral, contralateral issues. That is where you are you have like paralysis on one side of the body, and then the other side doesn't really have much sensation. And then your caudal Equila syndrome, that is where you have like loss of sensation like in that saddle area. So the way that I remember it is like Claudia cannot move or feel the saddle, like, you know, maybe of like a horse or something. Spinal shock. This occurs shortly after injury and can last days or to weeks. This is typically just like flaccid paralysis and total loss of motor reflexes. And then we already talked about neurogenic shock. And then autonomic dysreflexia. Let's see what else. Emergency interventions. Again, we just want to make sure the doctor knows how to bed up and maintain airway at all times. We always want to suspect a spinal cord injury until it's confirmed not to be. Always want to make sure that we maintain proper alignment of that spine, a stiff board, halo vest, maybe a cervical collar. Maintain that airway. Again, think of the body as one big unit. We're going to roll, a log roll all at the same time. We can do a trauma handshake, which would be like a finger and the patient's bottom to check baseline clench. So if they kind of clench, you can feel that they still have some control, but if they don't have any type of stimulation, that's not good. Acute care intervention. We want to watch out for respiratory pneumonia. Also any type of cardiac dysrhythmias. We want to check their pulse strengths. Neuro would be more of like their grip strengths, especially the level of that injury. We need to do that, like the neurogenic assessments, like the feeling like that little pen on the sole of the foot and what they have going on there. GIs, maybe check the distension of their bowel and bladder. Again, that is signs, if there is issues there, then that could put them at risk for autonomic dysreflexia. We want to make sure they have a high diet in fiber, maybe some Miralax, high protein. Renal, we want to make sure that they're having 2,000 milliliters of fluid daily, keeping that hydration up, checking to make sure they have adequate hydration would be with a Foley catheter, at least 30 mLs of urine per hour. Definitely at risk for UTIs. So we want to watch that. If they do, that could be some signs of fever and confusion. For their integumentary system, we want to make sure that we're turning and repositioning them properly, at least every 2 hours. Their psychosocial needs are very important. Want to make sure that they have time to express their feelings. There may be some sexual functions that are damaged, so we really want to be able to make sure that they are understood and we're able to validate their feelings. Some diagnostic studies, again, would just be the CT, cervical x-rays, MRI, comprehensive neurological exam. They may need some traction or realignment, stabilization of the injury and spinal segment. If they do have any type of pins, we want to make sure that we're checking the pin sites for signs and symptoms of any type of infection. Methylprednisone is given, and that's typically given to help relieve edema or any type of inflammation in the spine. Prophylaxis of heparin and Lovenox can be given. Any type of vasopressor agents like dopamine, norepinephrine, and epinephrine, those are going to help raise the blood pressure up. And then baclofen for that muscle spasms. It's a muscle relaxer and for pain. Some nursing diagnosis would be like impaired breathing, impaired nutritional status, or ineffective tissue perfusion. So overall, our goal should be to maintain optimal level of neurological functioning and high functioning as possible. So some nursing implementations, again, we talked about leg braces, halo ring, maybe some skull pins, and vest. These patients are not allowed to shower. They can only use the sponge bath. And that's it.